talking about the management. Now, there is a very nice expectant management regimen given by McAfee, that is known as Johnson and McAfee. Johnson and McAfee regimen. Okay, so what does it say? There is a goal to carry the pregnancy till term, because our goal is to save the mother as well as the baby. But the first goal is to keep the mother safe, right? So if we have to choose between the two, we have to keep the mother safe. But the goal is to carry the pregnancy to at least 34 weeks when the baby is out of danger. Okay, so goal is to carry pregnancy till term or at least 34 weeks without putting the mother's life at risk, with an aim to achieve fetal lung maturity. So fetal lung maturity, technically by 34 weeks, the risk is very, very less. So by 34 weeks, we can decide that we can deliver the baby, we can do a cesarean. Now, what are the indications for Johnson's and McAfee expectant regimen? Okay, there should be no active bleeding. She should be hemodynamically stable. Her gestational age should be less than 34 weeks, because if it is beyond 34 weeks, you don't need to wait. You don't need to put mother through so much trauma, okay? You can easily deliver the baby. What else? CTG should be reactive. No fetal abnormality. I told you there is a chance of fetal congenital abnormalities around 3 times more as compared to the normal population. So there shouldn't be any fetal abnormality. What are the common fetal abnormalities that we see? Polydactyly is very commonly seen, and many other congenital malformations are seen in the placenta previa. So if they ask you, polydactyly is one of the common abnormalities of the fetus. So there shouldn't be any abnormality. The mother should be absolutely safe, that we can carry on the pregnancy, and there should be no active bleeding. The CTG should be fine, and the gestation should be less than 34. Now, what happens between 34 to 37? Between 34 to 37 weeks, you can weigh what is best for the mother and the baby, and if you think there is no active bleeding, the mother lives very nearby to the hospital and she is ready to come whenever there is a problem, you can always wait till 37 weeks, because technically the term is at 37 weeks, right? But if you think that no, the mother cannot come back, she is already very, very tired and anemic, and she doesn't want to carry on more the pregnancy more, she wants the baby to come out because now the baby is good enough to come out and the weight of the baby is fine, you can think of a termination of pregnancy at between 34 to 37 weeks. All right. Now, coming to the expectant management steps. What are the steps? Now, these were the indications. What are the steps for this McAfee and Johnson's regimen, which was put forward in 1945? First of all, hospitalize the patient. Do her investigations, the basic investigations. So you have to hospitalize the patient, you have to do her CBC and sugar, that is a basic investigation that we do. Then you have to do a blood group, and if it is negative, give her anti-D because she is bleeding. BT, CT and coagulation profile is very important, because you have still not diagnosed whether she is actually a case of placenta previa. She's just come to you with bleeding. Moreover, even if you have diagnosed, even then she will need a BT, CT and coag profile, because she may be having some coexisting problem. There may be some DIC going on, there may be some APH abruptio going on, there may be some other coag profile problems. So you have to do all these tests, all right? You have to arrange blood, because obviously she is bleeding, she has come to you with APH, so you have to make sure that the blood transfusion is ready, depending upon her anemic levels, depending upon her HB levels. Then what else? You have to give her corticosteroids. Very, very important. Corticosteroids are not given now after 34 weeks, because we assume that the baby will be mature enough, but corticosteroids are given in the form of either betamethasone or dexamethasone. Okay? We will discuss this when we discuss preterm labor, the doses and all. So you have to give her corticosteroids. You have to make sure that the baby is safe. So you do CTG weekly. If she is having preterm contractions, you have to reduce the contractions. What kind of tocolytic agent will you give? The drug of choice will be nifedipine, which is a calcium channel blocker. Or you can give her magnesium sulfate, that is a neuroprotective. You will not give her indomethacin. We don't use indomethacin as such, but sometimes in the MCQs they might ask you. Indomethacin is not given because it is an antiplatelet drug. So as a tocolytic you will not give, and we know that it causes PDA also, right? Premature closure of the ductus arteriosus. So we don't use this drug anymore. Then there is terbutaline, which many people would use. Many doctors like using terbutaline, which is a selective beta-2 agonist, but that can lead to tachycardia. The side effect of selective beta-2 agonist is tachycardia and hypotension, and that is going to give you a false impression of shock. So don't use these two drugs. These two drugs are not used. So the ones which are used are nifedipine and magnesium sulfate. The drug of choice will be nifedipine if she goes into labor to stop the contractions. Okay. Now, as I told you before, if the patient wants to be discharged and she thinks that she can take care of herself at home, you are convinced that she is intelligent enough to understand the problems, you may discharge the patient. You may discharge the patient, and you can continue this regimen till up to 34 weeks plus minus 3 weeks, depending upon whether you want to continue and she's safe to continue till 37 weeks or not. Okay. In between, whenever you are doing this expectant management, if she starts bleeding again, then there is no role. Then there is no role of expectant management. If she starts bleeding again, immediately go for LSCS. Okay, you have to immediately do a cesarean section. Alright, understood? Now this is all about the expectant management. Now coming to active management. Why do we need to step into active management? Now it is very clear that you are trying to prolong the pregnancy to get the fetal maturity, not actually putting the mother at risk. But if at any time this expectant management is failing, then you have to step into active management, right? That is very, very obvious. So what are the indications? You have to, what is active management? To terminate pregnancy immediately, irrespective of the gestational age, you have to terminate the pregnancy. So when does it happen? Indications are when there is active vaginal bleeding, when there is hemodynamically instability, right? Stable is indication for McAfee's regimen, unstable is indication for active management. What else? Gestational age has crossed 37 weeks. So what is the point? What is the point of doing an expectant management? Plus the patient is in labor. She is laboring. So why are you waiting? What are you waiting for? What are the other indications? There is fetal distress. The baby is not well. So why are you waiting? Fetal distress, mother is not well, she is bleeding, the gestation has been covered, or the USG is showing that it is an abnormal baby. Now that obviously must have been diagnosed before only, but in case it was not diagnosed and you see that the baby is abnormal in sonography, you will be lucky enough to diagnose an abnormal baby at 9 months. It is very difficult because these things are picked up at 20-22 weeks, not after that. So if you see an abnormal baby, say for example an anencephalic baby, or you see a dead fetus, in that case, you don't have to wait, just jump into active management, deliver the baby. Okay? So I hope you have understood the indications for expectant and active management in placenta previa. Now coming to the summary of this management, the whole management. Now before I summarize what we discussed, what are the indications of cesarean section in placenta previa? Again, kind of same what the active management says. Major degrees, you will not go for the McAfee regimen. Major degrees are, you know, that it is type 3 and type 4. The previous classification type 3, type 4 comes in the major degrees. Dangerous variety. Now what is the dangerous variety? Tell me. Type 2 posterior placenta previa. Okay, so that is a dangerous variety. You will not go for a McAfee regimen. Severe bleeding, irrespective of the type. If she is bleeding, even if she is type 1, just go for cesarean. Fetal age less than 32. Now, if the baby is less than 32 and she is having bleeding, then there is a dictum whether you should wait or not. Now, this indication I would say is a question mark, because if she is less than 32 weeks and she is still stable, you can prolong the pregnancy for another 2-3 weeks. Let her go beyond 34 weeks. So this is still a question mark, depends upon what kind of question scenario they've given you. Okay, if it is very, very preterm baby, 24-26 weeks, and she is bleeding horrendously, there is no scope of McAfee's regimen, then yeah, you go for cesarean. But this one I would say is a question mark. Fetal distress, yes, if the baby is not well, you cannot wait, you just have to deliver the baby. Tell the neonatologist you are going to deliver a baby who is just about maybe 1200 grams or 1000 grams, and let them manage the baby. Now it is up to the luck of the baby and of course the expertise of the neonatologist how they manage the baby. Okay, so these are the indications for cesarean section in placenta previa.